Okay, so hi everyone. So today I thought I'll upload a video on previous year questions on NIMHANS. Okay, both post MBBS as well as post MD DM neurology entrance questions. So the best way to revise or reinforce any topic is by working out MCQs. So I thought I'll just discuss the MCQs on all the topics or all the classes I've taken till now. So I'll be discussing questions from 2010 to 2016. Okay, now let's go into the questions. Question number 1. A patient appears awake, is not talking, there are no voluntary movements, he can signal with vertical eye movements, CT scan shows an infarction of the ventral pons. What is the diagnosis? So it's very easy, classical clinical scenario, that is locked in state. So remember, locked in state is because of bilateral ventral pontine lesion. So in this condition, the patient is going to be quadriplegic with bilateral corticospinal tract signs. But however, the patient will be awake, but you won't be able to respond to any sort of stimulus. But however, vertical eye movements will be intact over here because vertical eye movements are controlled by the midbrain, whereas horizontal eye movements are controlled by the pons. So the only movement that you'll be able to do is vertical eye movements. So bilateral ventral pontine lesion, locked in state. Next, bilateral facial nerve palsy is seen in. So remember, there are 3 conditions that should come to your mind in bilateral facial nerve palsy. You should never forget. One is Guillain-Barre syndrome. Next, Lyme disease. And next is HIV. So these 3 are very important causes of bilateral facial nerve palsy. So the answer over here is Guillain-Barre syndrome. Okay. Most common site of hypertensive intracerebral hemorrhage. So remember, the 4 important sites are the putamen, the pons, the thalamus, and the cerebellum. So these are the 4 major sites of hypertensive intracerebral hemorrhage. But the most common of these 4 is going to be putamen. So the answer is putamen. So this is a very frequently asked question in NIMHANS. So don't forget, putamen, most common site of hypertensive bleed. Most common cause of subarachnoid hemorrhage is due to rupture of what aneurysm? Again, straightforward question, saccular aneurysm. Traumatic aneurysm, myocardial aneurysm, very rare. Myocardial aneurysm, very rare cause of SCH. So saccular aneurysm is going to be your answer. Saccular aneurysm is nothing but berry aneurysm. But in case they're going to ask you a question, what's the most common cause of SCH? It's going to be trauma. Trauma is the most common cause of SCH. The second most common cause is berry aneurysm. Okay. What are the causes of facial nerve palsy? Okay, causes of facial nerve palsy include all except what? So HIV, yes, can cause facial nerve palsy. Diabetes, yes. Multiple sclerosis, yes. Frontal sinusitis, no. Frontal sinusitis is not a cause of facial nerve palsy. So that's the answer over here. Next question. Which of the following statement is true regarding trigeminal neuralgia? Maxillary division is most frequently affected, yes. Mandibular division most frequently affected, no. Ophthalmic division most frequently affected, no. Actually, ophthalmic division is the least affected. Okay, so the least affected is going to be the ophthalmic division. The most common is going to be maxillary division. All of the above divisions are frequently affected, no. So the answer is maxillary division. Always remember, maxillary division most common. Least common is going to be your ophthalmic division of trigeminal nerve. Progressive multifocal leukoencephalopathy is due to JC virus. So those who have seen the video on treatment of multiple sclerosis will be able to answer this. So John Cunningham virus. John Cunningham virus is the most important cause, or is the cause of progressive multifocal leukoencephalopathy. That is why in MS, before you start natalizumab, okay, so natalizumab is a very potent disease modifying drug in multiple sclerosis. Before you start this drug, you have to check for antibodies to JC virus. If the patient is seropositive, natalizumab is contraindicated because of the high risk of PML. Okay, so always remember JC virus, PML. All of the following statements about Creutzfeldt-Jakob disease are true except it is a neurodegenerative disease, yes. It's caused by infectious prions, yes. Myoclonus is rarely seen, no. Myoclonus is the most commonly seen seizure type. It is the most predominant seizure type seen in CJD. Okay, and it's a very important feature of CJD per se. So this is wrong. Brain biopsy specific for diagnosis, yes. Okay, you're going to demonstrate prions in the brain biopsy. So which is a false statement? This myoclonus is not rarely seen. It is very much commonly seen in CJD. Next question. Devick's disease is associated with, again very factual question, aquaporin 4. So Devick's disease or NMO, you're going to have antibodies against aquaporin 4. In case the patient is negative for this, you always remember you have to look for anti-MOG antibodies, that is anti-myelin oligodendrocyte glycoprotein antibodies. In seronegative NMO, you have to look for these antibodies. The most common manifestation of multiple sclerosis is, the most common manifestation is always sensory disturbance. Sensory symptoms are the most common. The second most common is going to be optic neuritis. Since sensory symptoms is not given in the options, here you can go for optic neuritis. But remember, this is the second most common, not the most common, it's the second most common manifestation. Okay. Hunt and Hess scale is the grading system to classify the severity of subarachnoid hemorrhage. So remember, there are two prognosticating scales for SAH. One is Hunt and Hess scale, as mentioned in this question. Hunt and Hess scale. The second is World Federation of Neurosurgical Society scale. The first scale which was made is Hunt and Hess. This is a more recent one. The initial scale which was made for prognosticating SAH is Hunt and Hess scale. Also remember the other name, the other different scale is WFNS scale. Aquaporin 4 has been proposed as a primary autoimmune target. And again, repeat question, Aquaporin 4, that is neuromyelitis optica or Devick's disease. Repeat question. Most common site of intracranial bleed and hypertension is basal ganglia. Again, repeated question. Okay, if you want to be more specific, the most common site is going to be the putamen. Since it's not given in the answers over here, just basal ganglia is more than enough. You can also get in the pons and cerebellum, but remember the most common site is going to be the putamen or the basal ganglia. Okay. Sudden headache with LOC in a patient with renal cyst, subarachnoid hemorrhage with berry-aneurysm. So remember, you have to know the associations. Berry-aneurysm is seen in what other conditions? Remember, it is seen very commonly in autosomal dominant polycystic kidney disease. Then it is seen in fibromuscular dysplasia. Fibromuscular dysplasia. Then it is also seen in coarctation of aorta. Coarctation of aorta. See, this is three important, there are many associations, but you have to remember these three, they are commonly asked questions. So here we have ADPKD. So ADPKD is associated with berry-aneurysms, which can eventually lead on to subarachnoid hemorrhage. So remember again the concept over here, whenever you have a patient with sudden headache followed by LOC, it is always subarachnoid hemorrhage. Most of the time it's subarachnoid hemorrhage. Surgery for cerebellar hematoma should be done if the size is more than, okay, so if the size is more than 3 centimeters, you have to do surgery for cerebellar bleed. If it is 1 to 3 centimeters, you have to observe the patient. So you look for GCS, look for the pupils. If there is any impending signs of brainstem compression, you can go ahead and do surgery. Less than 1 centimeter, you can manage conservatively. You can manage conservatively. Okay, so you notice all these questions in NIMHANS and all these MCQs, they are directly picked. The lines are directly picked from the neurology section in Harrison's. So for those who are attending NIMHANS, both the post MBBS and post MD DM entrance, make sure that you are very much thorough with the neurology section in Harrison's, because this question is directly taken from Harrison's. Not only this, all the previous questions, they are directly picked up from Harrison. So it's very important that you go through the neurology section in Harrison's. Okay, so the answer over here is going to be 3 centimeters. The most common cause of intracranial bleed is, okay, so it's a factual question. Hypertension is the most common cause of intracranial bleed. The most common cause of subarachnoid hemorrhage, yes, tricky question. In a rush to answer, always will go directly take this aneurysm answer, but it's not aneurysm. The answer is trauma. The most common cause of subarachnoid hemorrhage is trauma. The second most common cause only is going to be berry-aneurysm. But if they ask you a question, what is the most common cause of spontaneous subarachnoid hemorrhage, that time you can tick berry-aneurysm as answer. But if they're going to just generically ask you subarachnoid hemorrhage, what's the most common cause, you should always tick trauma as the answer. Okay, next question. A person develops altered sensorium following headache and vomiting. What is the diagnosis? Again, like I tell you, whenever you have LOC, that follows headache. So severe headache leading on to LOC, first thing you should rule out is subarachnoid hemorrhage. So most of you will be confused between intracerebral hemorrhage and subarachnoid hemorrhage. But since here they specifically mention altered sensorium following headache, the answer over here is going to be subarachnoid hemorrhage. Vomiting is probably due to raised ICT. That can be seen in both of these. But why the answer is subarachnoid hemorrhage is headache followed by altered sensorium. Mortality in subarachnoid hemorrhage depends on, again this is a little tricky question. So perimesencephalic SAH, No, not really. Perimesencephalic SCH is a localized type of SCH, be very small. It doesn't have a bad prognosis. Site of bleed, not really. Not a very important factor for mortality. These two are the options where you're going to get confused. Because both delayed ischemia due to vasospasm and rebleed, both of them are major contributors to mortality in subarachnoid hemorrhage. So what option are you going to take? I think the best option over here will be rebleed. Because remember, rebleed has a mortality rate of 50%, which is significantly high. So it's between these two options. I think you can go ahead and tick rebleed as a important cause of mortality in SAH. The first scale of severity for subarachnoid hemorrhage is described by, again repeat question, scales in subarachnoid hemorrhage, Hunt and Hess scale. Always remember the other scale that could be asked in the future exams, that is World Federation of Neurosurgical Society scale, WFNS scale. Okay. Uthau's phenomenon is seen, and so those who have seen the multiple sclerosis video will be able to answer this question. It's multiple sclerosis. So basically in Uthau's phenomenon there is heat sensitivity. So whenever the patient has a hot bath, or the ambient temperature is going to increase, or the patient has some sort of fever, the symptoms are going to worsen. This is because heat compromises the already low nerve conduction velocity. So Uthau's phenomenon, remember heat sensitivity, classically seen in multiple sclerosis. Which of the following artery lesion involves third cranial nerve? So the answer is going to be posterior communicating artery. So remember that depending on what compressive symptoms are there, you can locate the aneurysm to some extent. So you can go ahead and look on my video on subarachnoid hemorrhage, where I've mentioned different aneurysms cause what type of different compressive symptoms. Always remember, third cranial nerve compressive symptoms, posterior communicating artery aneurysm is the answer. Pontine hemorrhage is characterized by pinpoint pupil, yes. Hypothermia, no. You're going to have hyperthermia in pontine hemorrhage. Hemisensory disturbance, no. You're going to have quadriplegia. The predominant neurological issue here is going to be quadriplegia with bilateral corticospinal tract signs. Hypertension, no. Patient is going to have hypertension, very high BP. So the answer over here is going to be pinpoint pupil. But remember, here the pinpoint pupils, they react to light. That's very, very important. Okay, maybe they can ask you another different MCQ where you have pinpoint pupil in both. You have two options with pinpoint pupil. One which is reactive to light, pinpoint pupil reacting to light, pinpoint pupil not reacting to light. So that time you have to trick pinpoint pupil reacting to light, because pupillary reflex is present in the midbrain. That is not affected over here. Here the lesion is in the pons, right? So whenever you have pinpoint pupils which react to light, you should think of pontine hemorrhage. An elderly patient presented with optic neuritis 2 years ago and is now presenting with facial nerve palsy. So here we have optic neuritis, we have facial nerve palsy. So are they both topographically related? No. So the lesions are disseminated in space. The optic neuritis occurs 2 years back. Now he's having facial nerve palsy. So the lesions are also disseminated in time. So which lesion or which condition you're going to have dissemination in space and time? It's going to be multiple sclerosis. That's the answer. EDSS criteria is used for. Again, little tricky question. Actually, EDDS criteria, we have something known as Kurtzky Expanded Disability Scoring System. Okay. So actually, this is a disability score. It's a disability score. It's not a diagnostic criteria. The diagnostic criteria for multiple sclerosis is going to be McDonald criteria. The diagnostic criteria is McDonald criteria, but the scaling, the prognostic scaling score or the disability scaling score is Kurtzky EDDS. So it's seen in multiple sclerosis. Okay, so that's about a discussion. I will discuss all the MCQs on the topics which I have discussed till now. So as I add new topics, I will discuss MCQs for them also. Okay, thank you.